So taking accurate blood pressure is a challenge. It's a challenge in a physician's office. It's a challenge by multiple different levels in healthcare. It's so much of a challenge that, in all honesty, they've changed what they say should be the routine ways to check blood pressure. It used to be that we would rely on a single blood pressure determination and using a wall mount mercury sphygmomanometer. The manual cuffs, also the aneroid cuff, is one we're used to. The challenge with the aneroid cuff is it ages. And the little bellows, the metal plate inside ages and fatigues. And so the aneroid dial, you want to make sure it doesn't have an automatic stop. If it has an automatic stop, then you don't know if it goes past zero, negative, and so you'll have inaccuracies. These do not have automatic stops, and so it's useful. They should be calibrated at least every 6 months. The aneroid, or the manual cuff, is challenging because, much like we've demonstrated in this series, it requires not only the clinician, whether it's a nurse or a health aide or the physician, to know the proper way that the patient is supposed to be sitting. Feet on the ground, back supported, comfortable, not rushed, and not tachypnic, and in no distress. Don't forget to consider the state of the patient. Are they stressed? Do they look stressed? Are they sweating? Are they breathing fast? Are they having phone calls going off in their pocket all the time? All those things that raise our blood pressure. So when you take a blood pressure in your clinic, you just need to take all those things into consideration before you even place the cuff. Clinically, I've had a number of patients that said it pumps up to 200 and never stops pumping up, and it's too painful. So if you have somebody who has an arrhythmia, you really can't monitor it with an automatic blood pressure cuff well. If somebody has fibromyalgia or a regional pain syndrome, just the pressure of a cuff that won't deflate adequately quickly is painful. And that episode can actually linger in the nerve memory for a period of time. So in your fibromyalgia patients, it's better to do a manual cuff than an automatic cuff. Those are the reasons now that I use to help determine when I'm going to use a manual cuff or an oscillating automatic cuff. To put the cuff on, you want to make sure that you have easy access to a shirtless arm. So if somebody is in tight wardrobe, tight shirt, tight sweater, you'll have to put them in a gown. This is ideal. He has a knit shirt that we're able to pull up above, right to his axilla. In placing the cuff, you want to make sure that when you palpate the brachial artery, that the artery indicator is right over, approximately over where the artery is, and then you do the folding of the cuff so that you have good purchase of the Velcro. When you first palpate the brachial artery, which is right there by the head of the biceps, you want to determine when the pulse extinguishes with insufflation of the cuff. That gives you a rough idea of what his blood pressure is. And then you are going to insufflate the cuff 20 points above that line when you begin to listen with your stethoscope and the bell of your stethoscope. Why do you do that? You do that so you can hear the 5 different carot cough sounds. Carot cough sounds are 5 different sounds that have been appreciated when you occlude an artery. You go beyond where you feel the pulse by 20 points, and you begin to back let the air out. The first crot cuff sound is a gradual increase tapping. The second, tapping followed by a slight murmur. The third is tapping again without much flow. The fourth is muffled, and the fifth is no sound. Those are just 5 descriptive sounds that you will hear when you use the bell of your stethoscope and listen to the blood pressure that you're taking with the patient. Of course, if you're using an oscillating cuff, you're not going to hear any of the crot cuff sounds. The crot cuff sounds are really not diagnostic. They're more descriptive. So when you're taking a blood pressure and you're blowing the cuff up, what do your eyes see? Well, you've already identified where the brachial artery is, but let your eyes go down the arm. Look at the hair distribution. Look to see if there's any sign of increased solar lenticos. Are there signs of chronic inflammation? Look at the nails. See if there's any inflammation around the cuticles. See if you see the lanula. See if you see any of the lines, any of the markers of leukonychia on the nails. So when should you consider checking simultaneous blood pressures in the clinic? Well, you may have had some clues. If you did oxygen saturation on the index finger of both hands in part of your exam, you may note that the oxygen saturation isn't as good in one finger as it is in the same finger on the other hand. Then you have to ask yourself, is that because of autonomic imbalance, dysfunction? Is that because of coagulopathy issues in one extremity versus the other? Is that because of a steal? When you see that asymmetry in symmetric limbs, you have to ask yourself that. So, oxygen saturation different between the index fingers on both hands. Do the patients feel one limb is colder than the other? And you've convinced yourself in your history, your timeline, and the clinical exam that they do not have any thrombotic event. So if that's the case, is that an autonomic issue? Is that a capillary issue? Is that a nerve issue? Is that a hormone issue? Well, to help distinguish, you can use the tools to help determine whether they feel cold and warm the same on each side. If there's any asymmetry, then you consider checking autonomic balance in each side, which the blood pressure cuffs help. The other thing you can do is, and you've seen this tool before, is you can use the infrared scanner that you look to see whether there is difference in the temperature at the same spot on each upper extremity. There is no difference. So that would also clue you to, I need to see if blood flow asymmetry is occurring. So let's say you believe there is blood flow asymmetry, or you think there's autonomic imbalance. The next thing to do is simultaneous blood pressures. Now, the great thing with automatic cuffs now, as long as the patient does not have an arrhythmia, and you've checked that, then you can do simultaneous oscillating blood pressure determinations. Again, the patient could not have an arrhythmia and use the automatic cuffs. If the patient does have an arrhythmia and you do want to check to see if the blood pressure is the same on both arms, you're just going to have to do manual determination in series. But let's go ahead and do this here. And while it's calibrating and determining, this is also the opportunity to consider what are the other nutritional things that might be playing a role. Okay, so if you have protein insufficiency, think of the roles of different amino acids, tyrosine, tryptophan, the normal balance of everything from dopamine to norepinephrine. Think about your one-carb metabolism, all the different nutrients that are involved in those steps that can play a role in not only blood pressure, but also in autonomic function. So what you see in this blood pressure and in that blood pressure is they are very close. These need to be within about 5 millimeters of mercury. To finish the nutritional component, no matter what the finding is, please consider, do they have enough amino acids to make the neurotransmitters needed? Do they have enough of the essential fats for normal neurologic and neural function, membrane health, mitochondrial function? Are they eating too much simple carbohydrates that increase their requirements, the B vitamins? Are they hypertensive? And you have to consider adequacy of riboflavin. What about the minerals? Well, it's the regular ones, right? So do they have too much or too little sodium? Do they have too much or too little potassium? Do they have too little magnesium? Are they doing anything that helps them clear and make them relatively insufficient of magnesium? The B vitamins are important, everything from thiamine to riboflavin. All these different nutrients that play a role, such an important role, that are components of food that can influence blood pressure and neurologic function in your patients, are well outlined in the companion guide. You may not often do simultaneous blood pressures, but there's a very important tool to help you see more in the patient in front of you. When checking the peripheral pulses and trying to determine if someone has peripheral vascular disease, one of the first things you do is make sure that you notice with their socks off and shoes off, it's hard to check pulses with them on, is that he has good hair distribution. He's had signs of previous scuffs and marks, but there's no sign of deep scarring or multiple issues with the skin. You still have hair on the top of the feet, which is usually a good sign that there's a good peripheral flow. When you're feeling the pulses, the mistake that many of us have gotten into is being really too heavy on the arteries when we're palpating the arteries on the feet. Come with a very gentle touch, and you'll often feel the pulses. If the question is in dorsalis pedis, and you find the hallucis longus tendon here, and it's going to be just medial to that, all right? And it's going to be midway down from the retinaculum. And sometimes you just have to quiet yourself to pick it up because it's not always bounding. And you often are going to feel it just fairly lightly under your finger. If you wonder whether it's your own pulse, go ahead and reach up and feel your carotid pulse and assure yourself that you're actually feeling the patient's pulse. So that sometimes you have to make a mark because that's where you're going to use your Doppler if you're doing ankle arm index. To go to the posterior tibial artery, which is absent in many people who have peripheral vascular disease, your positioning again is just behind the medial malleolus, and you should be able to pick it up. So if you have discrepancy between the two, you have to think about unilateral thrombus, arterial disease, white thrombus disease, and then you have to think about hypercoagulability. You know, in peripheral vascular disease and cardiometabolic syndrome, the same things that lead to vascular disease or vascular unhealth every place in the body, especially affects the most distal portion of the legs. So you're thinking about insulin and glucose, dysregulation. You're thinking about vascular or endothelial dysfunction. And you can really pick up if somebody's having trouble with adequate nitric oxide. You're going to have everything from decreased speed of perfusion, although his perfusion is great. Looking at his toes, you can check it here also. But the other things that decrease perfusion, not just a vascular disease from cardiometabolic syndrome, you have to think about vascular inflammation from autoimmune illness.